I, Dr. Madhura, on behalf of Pune Obstetrics and Gynec Society, welcome all of you for our cutting edge webinar series. So we've been doing these webinars every Tuesday, 4 to 5 p.m. with very crisp and clear messages on certain topics which will benefit everybody. We have been doing it with different societies all over the country, and today we are privileged to do it with the Ludhiana Society and Bhopal Obs-Gynae Society. Also, we are blessed to have dignitaries like Jaideep Madam with us and Iqbal Ahuja sir to bless the webinar. So, on behalf of Dr. Vaishali Chavan, I would like to seek blessings for ma'am as she contests for VP West Zone Foxy elections. So, I request all of you to support her. And without wasting much time, let us begin the webinar. Our president, Dr. Aarti Nimkar Madam, is unfortunately not available today, but we miss her. And I would request Vaishali Madam to say a few words at the beginning.
Thank you, Madhura. And I must say, I'm truly honored and truly blessed that our chief guest, Dr. Jaideep Malhotra, ma'am, is here, and Dr. Iqbal sir, guest of honor, sir, has also joined. And I must say some few words about Jaideep ma'am, because I'm truly blessed. I started my tenure as chairperson in Foxy under Madam. Madam was president Foxy at that time, and everything that I have learned is thanks to Madam. And we look up to her, and Madam has been inspiring us, guiding us, and encouraging us. And if all of us know about Madam, many achievements. She's been president Foxy, Aspire, ISAR, ISPAT, IMS, so many association. But still, Madam is so humble, so encouraging, so supportive. Madam, I am truly blessed that you're here today. And the Iqbal sir, we also need your blessings, and we are honored that you agreed to be our guest of honor. Thank you, sir. And Ludhiana OBGY Society and Bhopal OBGY Society are our partners today for this webinar, and we have named this Cutting Edge webinar. This we have been carrying on since 1 year. Every Tuesday, 4 to 5 p.m., we have these cutting edge webinars dealing with cutting edge topics. So thank you to Ludhiana OBGY Society, Dr. Guinea, and Dr. Shabana, Dr. Manisha, Dr. Shefali, Dr. Manu from Bhopal OBGY Society and Ludhiana OBGY Society. Thank you very much. I think we can start with the prayer, and then we can take Madam's blessings.
गुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. I would request Dr. Amol Lunkad sir to introduce formally introduce Dr. Jaideep Madam. Although ma'am needs no introduction, everybody is well aware of ma'am and her achievements. But as a formality, I request Amol sir to introduce ma'am.
Yeah, good evening, everyone. At the outset, on behalf of Pune Obs-Gynae Society, let me thank Ludhiana and Bhopal Obstetrics Gynec Society for being part of this webinar. And I welcome all the faculties and delegates over here. It is my proud privilege, and it is our privilege of all of us at Pune Society to have Professor Dr. Jaideep Malhotra Madam as the guest of honor today. Madam needs no introduction. She has been the president of so many societies and so many feathers in her cap. It is really encouraging to read about her. And I think knowing or reading her CV is just an encouragement to all the delegates to achieve so much and so far. So Madam has been the managing director of ART Rainbow IVF, immediate past chair of FIGO REI committee, member of accountability group of WHO, president-elect in SARC, and past president Foxy, past president ISAR, Aspire, the Menopause Society of India, then SAFOG, ISPAT, editor-chief of SAFOG and various journals and books to her credit. She has been the regional director of South Asia Ian Donald School of Ultrasound, and she has been the past secretary and vice chairman of ICOG. So she has had several awards to her credit, several achievements to her credit, and of course she has had several national and international publications to her credit. So welcome, ma'am, and blessing for this webinar.
Thank you so much, and a very good evening to all of you. It's such a pleasure, Vaishali. Thank you so much. You never forget me. And I have seen you growing, and working so hard with a lot of commitment and dedication. I'm sure in the times to come, you will definitely have a much, much better and meaningful role to play in Foxy. And may all your dreams come true. And dear friends from Bhopal and Ludhiana. Ludhiana has always been very, very close to me because I visited Ludhiana for a number of years, almost every other month, and have felt very, very privileged to have associated with all of you through the various organizations. And it's such a beautiful time. I think we are right now in the middle of the festivities, and these 2 months are full of energy and more positivity. And what we are bringing in today is a much, much better future for tomorrow. And Vaishali, I must congratulate you, because when I saw these 2 topics today, these are very less discussed and very less understood topics which you have actually chosen. And I really feel that this is something now, because most of the topics which we on a time to time are discussing are very repetitive. So both these topics are some things which I am sure whoever is listening to today's webinar is going to extremely benefit from the deliberations from the very, very nice speakers. And Iqbal sir, Sat Sri Akal ji, it's nice to see you. And it's really been a pleasure to know you for such a long time. So I would not take much time, and wish you all the best, and to each one of you, for all the speakers and all the members of these 2 societies, Bhopal and Ludhiana. Have a great day. Enjoy all the deliberations, and yes, please practice what you will definitely learn from today. Thank you so much for having me.
Thank you, ma'am, for your valuable words, wishes, and your blessings. And we just look up to you, and every word you say is so invaluable. Thank you for all your advice. And ma'am, I know you are so very, very busy, and we are truly touched that you remembered and you joined in with us today. And I think you're traveling, and this means the world to us. So thank you very much.
Always there for everyone. Thank you so much for having me.
Thank you, ma'am.
Okay, all the best.
Thank you.
Madhura, you are on
You're
mute.
mute. Madhura, you're on mute.
Yes, ma'am. So thank you so much, ma'am. Next, we would like to welcome Dr. Iqbal Singh Ahuja, who's our guest of honor. I request Dr. Meenakshi Deshpande, who's the secretary of POGS, to introduce sir.
Yeah, thank you, Dr. Madhura. At the outset, as the General Secretary of POGS, let me welcome Dr. Jaideep Malhotra, Madam, as a chief guest. And after hearing your blessings, Madam, we are very blessed to have you here today. And after AICOG Agra, we have met that time in the AICOG, and warm greetings that time you had given us. And we are still remembering AICOG Agra too much today also. I would like to introduce this guest of honor today, Dr. Iqbal Singh Ahuja, who is the director of Iqbal Nursing Home and Hospital in Ludhiana, the person who brought IVF technology to North India. Welcome, sir. Are you here? Dr. Iqbal Singh Ahuja?
Sir,
Yes,
join me.
Yeah. 5 years of dedicated service to medical, 55 years of dedicated service to medical field, worked as a senior consultant in CMC Ludhiana, and then started the first maternity nursing home in Ludhiana. It's called the Iqbal Nursing Home and Hospital in 1976. He's the pioneer of assisted reproduction in North India, He's trained in IVF from the State University Hospital, Vienna, and the Boone Hall Clinic, Cambridge, where the first test tube baby of the world was born. The first test tube baby of North India was born in 1992 in Iqbal Nursing Home. And he was felicitated with the State Award in 1992 by the Honorable Chief Minister, Beyond Singh, for the excellence in medical field. He was also received another state award in 1999 with the Honorable Chief Minister Prakash Singh Badal for excellence in social medical field. He was a state president of IMA Punjab, and he was honored with the Lifetime Achievement Award of IMA Punjab in 2010. He was honored with the coveted post of Deputy District Governor, Lions International, for prevention of female feticide in the year 2000. He's a founder secretary of Indian Menopause Society, Ludhiana chapter, and now a chairman. And he has contributed so many scientific and non-scientific articles. He's the author of short stories and famous for writing riddles in National Daily, The Tribune. He's a life member of American Medical Society, American Fertility Society, Indian Academy for Health and Education, and more. He's also giving scholarship to more than 100 students in various schools through his Baba Deep Singh Ji Shaheed Educational Trust. He has also received a Dronacharya Award for being the pioneer in IVF technology in North India by ISAR Punjab. To Sir, my journey into IVF since 1990, a world of closely guarded secrets. A small book he has written. My God, such a huge CV, sir. We are really blessed to have you as a guest of honor today for this cutting edge webinar by Pune Obstetrics and Gynec Society. Welcome, sir. I wish you say a few words for blessings.
Thank you very much. Actually, I am very pleased to be associated with the webinar today. Bhopal is a very good city and very famous. And I have got a special attachment with Bhopal because one of the girls I delivered long before, she was commissioner of Bhopal city for many years. I don't remember the name now, but she was a commissioner and she called me many times. So I have got a special attachment with Bhopal also. Usually, chief guests, except I will not say about the Dr. Chadin, she knows much more, but usually we don't have much knowledge as compared to the others sitting right in front. You are more intelligent than the chief guest and guest of honor. So I won't waste much time because choice was very good, anemia and thrombocyte. Patient is very happy with the sign of pregnancy. She is pregnant. Our doctor is very tense. Severe anemia in the patient and thrombocytopenia. Both diseases are difficult to treat and doctors are at risk. I think I am very happy to be associated with it. Thank you very much for making me a part of it. I will not be taking too much time because the time is more precious for the webinar. Thank you very much.
Thank you, sir.
Thank you, sir, for your
Thank you.
blessings and your good wishes for us and for the webinar. And Pune Gynec Society is truly indebted to you for your presence here and with your great expertise. I'm sure our webinar is going to be enriched with your blessings and your good wishes. And we are truly impressed by reading your CV. And you have been a pioneer in IVF, and it's an honor to have you today with us as guest of honor. Thank you, sir.
Thank you, sir. So we begin our first session, for which I would like to invite our esteemed chairpersons who are from Bhopal. Unfortunately, Dr. Shabana Sultan, she's not able to join as she's stuck with a case of placenta accreta. She's the HOD of Bhopal GMC, so she's stuck with a case, so she can't join. I welcome our other chairperson, Dr. Manisha Jain, who's from Bhopal. She is the treasurer of Bhopal OBGYN Society. She was the organizing secretary of VPCon 2024, member Executive Committee AMPOGS 24 to 26. She was the organizing committee member ISAR Bhopal 2023, organizing committee member of AMPOGS 2024 Jabalpur. She's an executive member of MPAGOI. She has won the Best Paper Award at MOGS OBS NCT Conference 2021. She's been faculty to many national and international conferences, AICOG.
Thank you, ma'am.
And she's a professor at PCMS and RC Bhopal.
Thank you so much,
Yes,
ma'am, for the
welcome,
kind
ma'am.
work and for the invitation. I'm really indebted to all the Pune Obstetrics Society, Dr. Aarti ma'am, Dr. Meenakshi ma'am, and Dr. Ramol sir for inviting me and making part of this event today. It's my really honor to have a distinguished guest for today, Jaideep sir, madam, and Dr. Iqbal Singh sir with us. And today is a very important topic that we are discussing is cutting edge webinar that Madam series is started on very important topic of thrombocytopenia in pregnancy. I'm really honored to invite to speak Dr. Vaishali Chavan ma'am. She is the past chairperson of the Perinatology Committee FOGSI. We have seen her work, and she's really a very great academician and very hardworking. She's also the clinical director of the Cloudline Hospital, Kalyani Nagar. She is director of Sanvi Clinic Women's Health Center. Madam has been the vice president elect for the Pune OBGY Society for next year. She is she has held the post of honorary general secretary Pune OBGY in 2024 and has various publications, chapters to various books, and has immensely contributed in different FOGSI focus and international publications. She has been the recipient of various awards, especially the Punya Bhushan Award in 2017, Samaj Bhushan Award, and many more. It's really my honor to have you, ma'am, today. Over to you for the talk.
Thank you, Manisha ma'am, for your kind introduction. And truly an honor to be introduced by you. And thank you for being with us here today. I would like to just share my screen, Mr. Prasad. And we are looking forward to hear the next talk. So I'll try to finish my talk quickly with the relevant and clinical points. Mr. Prasad, can you see my screen?
Yes, ma'am, visible.
Yeah.
Yes.
Yes.
So my topic today is thrombocytopenia in pregnancy, and this indeed is a very important topic, especially nowadays with rising dengue, and we see patients who come with less platelet counts, and nowadays the patients have become more aware, and they come to you with their CBC report and they say, "Madam, have you seen my platelet count? My platelet count is less. It's less than 1 lakh. Have you seen that? I have low platelets." So patients are aware nowadays that their platelet is low. So it is indeed an important topic. Yeah. So this is the city of Pune, and talking about thrombocytopenia in pregnancy. Of all the thrombocytopenias that happen, the ones that happen in pregnancy are 6 to 10%. And amongst this, the commonest is gestational thrombocytopenia, and that is as high as 70 to 75%, which is a good thing because gestational thrombocytopenia actually is not a serious entity. The other causes of thrombocytopenia could be HELLP syndrome, that is as high as 21%, or it could be idiopathic thrombocytopenic purpura, or also known as autoimmune, which is present in a more serious way. And so talking about the hematological changes that occur during pregnancy, and during this time, thrombocytopenia is one such change. And we know that pregnancy is a thrombogenic state. So when there's a patient who comes with thrombocytopenia report and she's pregnant, we need to categorize whether this thrombocytopenia, is it related to pregnancy or is it due to some other cause which is not related to pregnancy. So for causes related to pregnancy, almost 70 to 80% causes is gestational thrombocytopenia, and it is only in the remaining 20% to 20 to 30%. It could be due to severe preeclampsia, could be HELLP syndrome, could be acute fatty liver or pregnancy, and so on. And the causes which are not related to pregnancy could be AITP, drug-induced, type 2B1 Willebrand disease, congenital thrombocytopenia, TTP, hemolytic uremic syndrome, and SLE, and infections, bone marrow disorders, and so on. So the various hematological changes that occur in pregnancy, the platelet count as such doesn't change much. It falls only by 15%. And talking about platelets are actually very small cells. They do not have nuclei, and the average lifespan is just 4 to 10 days. And if you see, and as we know, platelets are generated in the bone marrow, and they are destroyed or sequestered by the spleen. And if you see the relative size of the platelets are really very small. And if you see this peripheral smear, the small tiny blue dots that you see are the platelets. So classification, why thrombocytopenia occurs? Either there is the platelets which are there, they are excessively destroyed, and that could happen in autoimmune thrombocytopenia, or it could be a non-immune mechanism also, like pregnancy or viral infection. Or there could be the production of platelet itself could be less, and that happens in aplastic anemia, leukemias, myelosuppressive drugs, and so on. Or there could be abnormal pooling of platelets, happens in splenomegaly due to congestive infiltrative neoplastic diseases. Platelet disorders can also be due to numbers like thrombocytopenia. There could be thrombocythemia also. And when you see a patient who has come to you with a report and it shows that yes, the thrombocytopenia, platelet count is less than 1.5 lakh or platelet count is less than 1 lakh, then what should you do? What are the practical tips? First of all, it is important to rule out, it's important to reconfirm, ask the lab to do a manual platelet count. If required, get a second report from some other lab. See if there's a plug formation. Sometimes the platelets forms a plug in the EDTA bulb, and because of that also the report can be faulty. Review the peripheral blood smear, exclude whether there's any fibrin clot, and repeat the CBC sample, and this time do not send an EDTA bulb but send in citrate sample. So it is only after reconfirming again and again that you reach the diagnosis that yes, this is thrombocytopenia. So if the patient has come with thrombocytopenia, how do you approach? A detailed, careful history is very important. A confirmation about any previously undiagnosed bleeding, undiagnosed signs of thrombocytopenia. Review the maternal platelet count, any past medication history, detailed examination, whether there's kind of bleeding, petechiae, ecchymosis, which usually occurs on the mucosal surfaces. And after the detailed clinical approach, ruling out any comorbidities, SLE, infections, and so on, it's also important to know if patient has had any pre-pregnancy platelet count, and is it that the platelet count has dropped only during pregnancy. So gestational thrombocytopenia, talking about this GT in more detail, it is the gestational thrombocytopenia is the majority of our patients have this. 70 to 80% of the patients of thrombocytopenia present as gestational thrombocytopenia. And we need not really worry about this. And it's important to counsel the patients also, because is there a risk for bleeding for mother? No, there is no risk. Is there a risk of fetal thrombocytopenia? No, the risk is not increased at all. And why does it happen in the first place? There could be hemodilution, or there could be a more turnover, trapping, or destruction. So how do you manage gestational thrombocytopenia? So usually it is mild, it appears late in pregnancy, and it can be quite difficult to diagnose. So always the diagnosis is by exclusion. Does it mean that patient needs a cesarean? No. Patient can deliver normally, but cesarean can be done only if there's an obstetric indication. How do you monitor this patient? So you need to monitor this patient regularly, reevaluate the platelet count. And as such, these patients do not require platelet transfusion or glucocorticoids or steroids or IVIG. And in the subsequent pregnancies also, these patients may have gestational thrombocytopenia. And 70% cases, the platelet count is between 1.3 lakhs to 1.5 lakhs. It rarely goes less than 70,000. So in gestational thrombocytopenia, the platelet count is always more or less more than 70,000. Is there any kind of therapy required? Not really, but monitoring maternal platelet count frequently is required. It is also important to see the differential diagnosis of thrombocytopenia in pregnancy and ascertain and rule out that this is gestational thrombocytopenia and this is not autoimmune thrombocytopenia or HELLP syndrome or any acute fatty liver of pregnancy and so on. So AITP or thrombocytopenia, which occurs, it's an autoimmune disease. It occurs due to antibodies induce peripheral platelet destruction, and autoimmune thrombocytopenia may need treatment with steroids, IVIG, and so on. Preeclampsia, we know how to diagnose it. HELLP syndrome, we need to rule out. Acute fatty liver of pregnancy is a very, very rare disease, less than 0.1%, but it is highly, the morbidity and the mortality rate is quite high, or hemolytic uremic syndrome, and so on. So differentiating between the thrombocytopenia and what is the reason, whether it is just gestational or the severe preeclampsia, HELLP, acute fatty liver, HUS, and so on, is very important. So how do you evaluate? What are the lab investigations that are required? You do a complete blood count, reticulate count, peripheral blood smear, liver function test, viral screening. And only if it is indicated, then only you go ahead and do antiphospholipid antibodies, ANA, thyroid test, DIC testing, and so on. So now coming to the next, that is the idiopathic or thrombocytopenic or autoimmune thrombocytopenic purpura. And this is what we are worried about. In this, the platelet count of the patient is quite low, less than 70,000. Sometimes it can go less than 50,000. And this is because of the antibodies which are bound to the platelet and they are rapidly cleared from the maternal circulation. Is there any diagnostic test for this? No, unfortunately, there's no diagnostic test for ITP, but the degree of thrombocytopenia, if the platelet count is less than 70,000, less than 50,000, then we suspect that yes, this could be autoimmune or ITP. And ITP is a hematological disorder. It's important to remove that here what happens is the autoantibodies destroy the platelet. And these antibodies can travel through the placenta and they can cause harm to the fetus. It can cause fetal thrombocytopenia and it may even cause neonatal thrombocytopenia. So how do you differentiate between gestational thrombocytopenia and ITP? In ITP, the count is less than 70,000 and it is induced by antibodies and may require treatment. So when you have a patient with ITP and there's a specific protocol of managing it, it's important to remember the values of 80,000 platelet count, 50,000 and 30,000. If the patient has platelet count less than 80,000, then it's important to know whether she's more than 32 or less than 32 weeks. If she's more than 32 weeks and platelet count more than 50,000, then you just need to review the patient and reassess the patient and wait and watch. No active treatment is required. But if she's more than 32 weeks and platelet count is less than 50,000, then steroids may be given or IVIG can be given. In case patient is less than 32 weeks of pregnancy and platelet count is less than 30,000, then again steroids, IVIG, and only in refractory cases where patient has not responded to steroids or IVIG, even during second trimester, laparoscopic splenectomy is also recommended. Anti-D, azathioprine are also drugs which have been used with varying success. So the treatment for ITP is corticosteroids, IVIG, and azathioprine. Laparoscopic splenectomy is a rare thing only in refractory cases. And of course, platelet transfusion can be given, single dose single donor SDP increases platelet count by 30 to 40,000 and RDPs increases only by 8 to 10,000. So ITP management, it's important not to panic. The risk of excessive bleeding is only if the platelet count goes below 20,000. So even if you give corticosteroids and you give IVIG, the platelet count is going to increase. So there is no need to panic. And transfusion of platelets can be given SDP and IDP. And IVIG for 2 days also has shown to rapidly increase maternal platelet count. And I have recently managed a similar case along with a hematologist where patient was given, it was a planned cesarean. So 2 days before the planned surgery, she was given IVIG and the platelet count really rose. and we did a section, and everything was uneventful, and patient was discharged uneventfully. So delivery, coming to the delivery part, mode of delivery is decided only by obstetric indication. But it's important to know that avoid forceps or vacuum. And regarding anesthetists, well, the American Society of Anesthesiology, they have given guidelines that more than 80,000 platelet count is required for regional anesthesia. Is the fetal or neonatal thrombocytopenia, does it happen? It may happen. 30 to 40% of infants may be born with thrombocytopenia, and neonatal thrombocytopenia usually worsens during first days of life, and it can last up to 10 to 60 days. So how do you diagnose ITP? Unfortunately, there's no definite method. It is a diagnosis of exclusion, and even IgG autoantibodies can be detected by immunofluorescent technique, but it's not really recommended. So what is really needed to manage this patient is a multidisciplinary approach with a hematologist, obstetric unit, neonatologist, and ICU if whenever required. So it is important to realize, that for ITP, the fetus and the neonate are also can be affected. In puerperium, the physician should also document the normalization of the platelet, and this again is a very important point. So when the newborn is born, this close monitoring should occur 24 hours, day 3 and day 5, and breastfeeding is of course encouraged. Now, seeing the other causes of thrombocytopenia, you should be able to rule out whether there's HELP syndrome, or because we know HELP has poor prognostic criteria. What are the prognostic criteria as we are aware about it? We need to also rule out the classic pentad of thrombotic thrombocytopenia purpura, that is a TTP, and also acute fatty liver of disease, which is a rare, but it can be a life-threatening disease. So hemolytic uremic syndrome is another differential diagnosis and reason why there could be thrombocytopenia. So basic principle to remember is never panic and rush into giving platelet transfusion, and patient really doesn't bleed unless platelet has gone below 20,000. For normal delivery, you can deliver patient even below 20,000, and for cesarean, less than 50,000. 50,000 is the cutoff. So you can either give single dose, single donor SDP, or RDP, whatever is available, and ABO and RH compatibility is also very, very important. So take home message here is we are seeing a lot of thrombocytopenia cases right now, and gestational thrombocytopenia is one of the commonest hematological disorder. Number 1 is anemia, and number 2 is gestational thrombocytopenia. And diagnosis of TP is a diagnosis of exclusion. Platelet transfusion is not really, should not rush for platelet transfusion unless it is absolutely indicated. So thank you everyone for patient hearing, and thank you very much.
Thank you so much, ma'am. It was really a very wonderful talk, very well timed, and you covered everything, almost all the topics. We know that we come across thrombocytopenia in and out quite frequently these days because of institutional delivery. And yes, you very rightly said we did not rush, should not panic and rush to start platelet transfusion, but definitely a careful evaluation of the underlying cause is very important. And then starting the treatment as per the cause is the key to manage such patients. Thank you so much, ma'am. It was really nice listening to you. I look forward to more talks and more involvement with the Pune Obstetric Society. Thank you so much. Over to Dr. Madhura for further proceedings.
Thank you, Manisha ma'am, for your kind words and your expert inputs. And it's truly a great honor for us to have you all with us today with Pune OBGYN Society. Thank you.
Here. Same here. Thank you so much.
Thank you, ma'am. Thank you so much for being here and for your valuable words. Let's move ahead with the second session, which is going to be with the Ludhiana OBGYN Society. I request Meenakshi ma'am to introduce both our chairpersons for the next session.
Yeah. After that wonderful first session, now we move on to the second session. I invite the chairpersons Are we having Dr. Manjula Singla and Dr. Shefali Sood over here?
Dr. Manu Singla.
Manu Singla, yeah. Dr.
Manu
Manu
Singla.
Singla, she's there.
Yes,
Yes.
ma'am.
Yeah. And Dr. Shefali Sood. Yeah. So I invite Dr. Shefali Sood. She's a consultant gynecologist at SPS Hospital, Ludhiana. She's got 10 years of experience in obstetrics and gynecology. She's a diploma in infertility with Delhi Gynecologist Forum. And also she's a diploma in cosmetic gynecology. Her areas of interest are laparoscopic surgery and high-risk pregnancy. So welcome, Dr. Shefali Sood. And I would also now like to invite the second chairperson, Dr. Manu Singla. Dr. Manu Singla is an MD Gynac from DMCH, currently doing private practice at Singla Hospital, High Bovile, Kallan, LDH from last 20 years. She's a life member of FOXY, IMS, SFM, presently Secretary of Ludhiana Obstetric Society. Her areas of interest are high-risk pregnancy and ultrasound. Has participated as faculty in many national and international conferences. So welcome, Dr. Manju Singla. And I welcome you both the chairpersons and hand over the session to you for the next introduction.
Thank you, Meenakshi ma'am. Thank you, Pune OB-GYN Society, for involving me in this cutting-edge webinar on anemia, which is a major cause of morbidity, especially in women and children, as almost 30% of females, they suffer from anemia. This number rises to 50% in pregnancy. Even 60% of children, they suffer from anemia. It is very important to find out the cause of anemia and to rectify the anemia. Now I invite Dr. Ginni Gupta, our dynamic president of Ludhiana Obstetric Society, for our next lecture on anemia. She is president Ludhiana Obstetric Society. She is consultant at Healthline Hospital, Ludhiana. She is visiting consultant at Cloud9 Hospital, Ludhiana. She is member of SFM, SMC, FOXY, AIWF. She is Manyata champion and coordinator of Punjab. She has been a faculty at numerous national and state level congresses. Her field of interest are safe motherhood, high-risk pregnancy, and adolescent gynecology. Now I invite Dr. Ginni to take over for the next session.
Thank you, Dr. Manu, for a sweet, sweet introduction. I would like to pay my respects to our father figure, Professor Dr. Iqbal, who is here with us, showering his blessings always. And Dr. Vaishali, your brilliant talk. All the members of the Pune OB-GYN Society, thank you for involving us and giving us this beautiful platform to interact with you. So please, my topic is very simple, but still it needs, simple things need to be reiterated daily so that we do not forget the simple things. And I would just like them to allow me to share my screen. Am I? Am I audible, Dr. Manu?
Yes, yes.
Okay. We are using this working definition. Anemia in pregnant women is defined as hemoglobin less than 11. And of course, we know it is further classified as mild, moderate, and severe. So iron deficiency is the most common cause of anemia in pregnancy. And it's a very, very grave issue around the world. 14% of developed countries also, the pregnant women are anemic. But in our country, 56%, this is a very high number. And this is a data which is derived from a study published in Lancet. IDA was also estimated to cause 22% of maternal deaths. Over a third of all pregnant women, just as Dr. Manu also said, they are anemic. In India, our great Bharat, 326,000 estimated maternal deaths are due to iron deficiency anemia approximately. and 12 lakh, almost 12.5 lakh associated, no, it is 1 crore and 24 lakhs associated disability adjusted life years due to anemia were caused. So, what are the determinants of anemia in women of reproductive age? So, in India, I would say that the social structure, the cultural habits, the food, and some dietary and some religious practices like fasting on at least one day of the week. There are many, many factors. Then there are community factors. In some communities, we have early marriage, multiple childbirths. They do not use contraception. Although our country is changing, but social, cultural, and economic, that is the rural well as the semi-urban or the urban areas, there is a lot of influence on the cause of anemia. So then there is also in our part of the country, Punjab, Ludhiana, genetic hemoglobin disorders are a very big issue because we are almost a little short of endemic for thalassemia minor, beta thalassemia minor. We have hemoglobin Punjab D heterozygous. We have sickle cell trait commonly picked up in OPD. We have sideroblastic anemia picked up in OPD, and we have hereditary spherocytosis also. So there are these are the causes of anemia which we have to keep in mind while treating our other most of the whole population of the anemic OPD, because in there the management will be different. So then the other factors will be maternal, the early onset of childbearing, as I mentioned, then the dietary intake to diverse food sources. Well, the food choices that the population is increasingly making, which are more carbs, starting from adolescent and to the middle age, high carbs, high potatoes, and less greens, no non-veg, no egg eating, and the heme iron source is very, very limited in our in this part of the India, although Punjab continues to be a little better for the non-vegetarian food. Then access to health services utilization, access to antenatal care. Well, this aspect I would say is a little better in Punjab because we are mostly urban, but even the suburban areas have a lot of postgraduate obstetricians working who are able to quickly identify anemia and treat it. So then the socioeconomic, as we've already talked about it, and the ecological factors. Within the ecological factors, I would also say that the health policies and systems also influence cultural norms and behavior like fasting, and the dietary patterns like the lentil intake that we do, the cereal intake that we are doing, and which inhibits the dietary iron absorption, then the high intake of tea. So after that, we just take a look at pathophysiology of iron deficiency and iron deficiency anemia. Why does it occur? Why is the pregnant woman suddenly, why she's affected so much? Because with the increasing pregnancy gestation, there is a dilutional effect of the blood. RBC expansion occurs only 25%, while the blood volume is doubled. So definitely there is a dilution. Then the placenta, it is such a rich and vascular organ, and it eats up a lot of hemoglobin due to its inherent structure. Fetal requirement. Again, the metabolic and oxygen delivery needs of the fetus also drain the mother. So if you look at the iron requirement, it is 9 times higher during pregnancy. And this is the second and third trimester, the iron requirement is almost 7.5 milligram per day. So we do not know whether the lady is taking this or not. Most of them, of course, are not. So what are the guidelines for anemia screening? The ACOG recommends the anemia screening with complete blood count first trimester, then again at 24 to 25 weeks, and then 28 weeks onwards. But we feel that in India, definitely the first screening with CBC should be there, but practically most of us are 4 to 6 weekly doing a hemoglobin estimation after getting a baseline CBC and ruling out the hemolytic pathologies. The screen for anemia, the RCOG recommends booking at 28 weeks, and those with multiple pregnancies, additional CBC at 20 to 24 weeks. So what is the main, most of us have abundant only hemoglobin, which was taught to us while we were PGs to do the hemoglobin with the hemoglobinometer even in the labor rooms. Well, because it is easily available, it can be quickly done, but then we have to remember that there is a lack of sensitivity to detect the early stages of iron deficiency. It cannot be utilized to diagnose just anything other than a low hemoglobin. So an absolute dependency on hemoglobin concentration lacks adequate sensitivity and specificity for the diagnosis of iron deficiency anemia. And in the past 2 decades, where the laboratory investigations are so widely available with the well standardized ISO 1000 certified labs, so other biomarkers, particularly a very common one which is available is serum ferritin. Now, ferritin represents the iron stores and it is a very excellent marker. We know that below 10 we have iron deficiency, below 3 is severe, and we are also able to pick up the iron overloaded states and hence the hemolytic nudge towards that. So the other markers are hepcidin and the total iron binding capacity saturation. There are other newer parameters which I won't go much into detail. There is chronic reticulocyte, reticulocyte hemoglobin content, then hypochromic microcytes and hypochromic reticulocytes. And then there is a ratio of the microcytic RBC and the hypochromic RBC. So as a non-pathologist, we do not know much of the utility, but definitely measuring the functional available iron over 3 to 4 days and an early indicator of iron deficiency anemia response to iron therapy with reticulocyte hemoglobin concentration. So iron deficiency anemia in pregnancy is associated with now another side effect. It leads to the anemia after delivery, postpartum anemia. And postpartum anemia is another morbid situation for the mother and baby. It causes impaired quality of life and physical and mental health. Presence of anemia also in the postpartum period is determined by the magnitude of the peripartum losses. And diagnosing postpartum anemia is a very important thing because the postpartum period becomes not only complicated, the mother is chronically fatigued, chronically suffering from many pains and aches and not able to perform good postpartum duties. And so much so severe anemia at this time would lead to lactation failure or subinvolution of uterus and so many complications which we know of. So according to the WHO, postpartum anemia is diagnosed when HB is less than 11 gram 1 week after delivery, and if you wait for 7 days, then less than 12. So unresolved antenatal iron deficiency or anemia will lead to PPA. During pregnancy, it will persist after childbirth and or excessive blood loss. It is associated, as I mentioned, tiredness, breathlessness, palpitations. In fact, in our local heart center, there are studies going on which show that women who are chronically anemic through successive pregnancies have a higher risk of peripartum cardiomyopathy also. Not only that, it reduces cognitive performance, emotional instability, postpartum depression. And many of the women nowadays, they go back to work. So they will go back to work anemic, like after 6 weeks or whenever the maternity leave is over. So what are the treatment modalities and what were the traditional ones which we had and how do we fulfill their shortcomings? Lifestyle changes, dietary modifications and supplementation definitely is there, but lifestyle modification, we can modify a lifestyle like the bad habits. Smoking is a very bad habit which is coming on as a status symbol even in the urban areas in Punjab and northern India greatly. We need to stop this because smoking inhibits iron absorption. And coffee intake, which is so high, especially in the corporate employed girls, the bankers, the CAs, the drinking of too many cups of tea. Tannins from tea and coffee are known to inhibit absorption of iron from food. So we need to discourage these habits, especially when these young ladies come to us for preconception counseling or even in first trimester. So, lifestyle associated problem, which is not mentioned here, I would suggest modification of diet to include a lot of green leafy vegetables, prenatal supplementation of folate, and if prenatally they come to us, then at least a complete blood count and try to correct anemia before pregnancy, before they conceive. So in the lifestyle, not only cereals, we could encourage them to take the heme sources of iron where religion and lifestyle is not an issue. So actually, it is seen that nutritional supply of iron is lower than the need of pregnancy. In the first trimester, only 35% comes through the nutrition as versus the demand. In the second trimester, 37%, and in the third trimester, only 41%. This is reported by an Indian diet, which is now consciously the population which is fortifying their diets with the iron-rich foods. Even in them, the dietary fortification and supplementation is not able to supply the demand. Plant-based foods from the main sources of dietary iron for pregnant, that is spinach, beetroot. Chicken is quite eaten, but it is not having heme iron. But the meat factor effect is there. Amino acids in chicken with sulfur exert a positive effect. Cereals have a positive effect because they contain protein, but cereals actually contain phytates and oxalates, which inhibit the absorption of iron. We have to encourage fruits rich in vitamin C, and ascorbic acid prevents the formation of ferric compounds and enhancing iron absorption in the presence of phytates. And they must go again tea, coffee. So supplementation is the key. Diet alone is not going to fulfill the demands. When supplementation is inadequate or it doesn't occur, first the bone marrow iron stores are triggered because we know that the fetus and the placenta are going to get everything by active transport. So there will be a depletion of iron stores. Iron will be mobilized, leading to more RBC production and increased retic count. Then a decrease in serum ferritin will be seen in the and a decrease in hemoglobin of nearly 0.5 gram per deciliter is recorded by the end of pregnancy. So this is how the anemia sets in the absence of adequate supplementation. Now, management. This is a busy slide which shows that if HB is less than 11, then what do we do? So broadly, we first try to see that if what are the iron stores, because ferritin is telling us the stores. If it is less than 30 nanogram, we know that she does not have iron stores. So she is unlikely to be a hemolytic disease, because the hemolytic anemias, the thalassemias, they are usually iron overloaded states. So less than 14 weeks, oral iron we give, then 14 to 28, again we give. And if hemoglobin is lesser than 9, or if she is later in pregnancy, then as I go earlier further, I will elucidate that what are the situations in which we will recommend the parenteral iron. So the first will always be to give oral iron trial for 4 to 6 weeks and then recheck if the patient has responded or not. So with increasing gestation and with no response or intolerability to oral iron will come in the role of intravenous irons. Then in cases ferritin is more and we are suspecting this hemolytic pathologies or some other anemias other than IDA, if the mean corpuscular volume is less than 80, then we will do the hemoglobin electrophoresis to rule out the hemoglobinopathies. And if the mean corpuscular volume, the macrocytes are there, and definitely B12 and folate acids. Now, oral iron, definitely it is the first line in the treatment of iron deficiency anemia. The higher serum ferritin levels are observed when oral iron supplements are taken between meals or at bedtime. And it is, since more than 5 decades, we know that the dose of oral iron is directly proportional to improvement in hemoglobin level, while GI disturbance continues to be the limiting factor. And even the alternating dosing of elemental iron is known to significantly increase total iron absorption. So look at the different iron preparations available in the market. Ferrous iron salts, they are inexpensive, widely available, but the main, I would say, musibat in the way, the reason why the patients are not taking them is the GI side effects. So polysaccharide iron complex are less effective in raising. So they have mostly gone out of repute. Now, heme iron has a higher absorption rate, expensive, but again, for the majority of our vegan population or the vegetarian population of India, again, they will not eat it. So carbonyl iron, again, the efficacy has never been so much as the ferrous iron salts. So I would like to come to the bottom of the list, the iron amino acid chelates. Iron amino acid chelates continue to play a big role because they contain iron amino acid complex. They have very little dietary interactions, but the low dose, even up to 30 milligram per day, can be given even in the first trimester onwards, which recently FOGSI has endorsed. So now the drawbacks of oral iron therapy. For so many decades, we've been using it. It has adverse GI side effects. You start iron after the NT scan sometimes if you're not giving in the first trimester, and she comes back after a week or so with terrible side effects and cursing you. Then because of side effects, there will be lack of adherence to therapy, or she will just stop taking it and not tell you, and then the HB will go on decreasing. Then the length of therapy is usually insufficient because since times immemorial, we are not giving it in the first trimester. It is now that iron amino acid chelate is improved. It is endorsed globally to be given in the first trimester also, a low dose, that is 30 milligram. then it requires a lot of intake. So 6 months to khani padti hai. Limited duodenal absorption due to concomitant well. There is a lot of inflammatory bowel disease everywhere. Now, are blood transfusions a better thing to correct anemia? No, of course not. They have their role in only severe iron deficiency where rapid anemia correction is necessary clinically when you are faced with a delivery or there is an ongoing blood loss, and when patients no response to dietary iron and they have some contraindication to the intravenous iron, especially in our part of the area. We cannot give IV iron to our thalassemia minors, our carriers of sickle cell, and we cannot give it to the patients with these hereditary spherocytosis. So blood transfusion has other risks also: incorrect transfusion, adverse impact on the immune system, infection, and there is a big issue of nucleic acid testing of the common viral diseases, which is nucleic acid testing is not available in most banks, even in the north. So other things, social issues, patients' beliefs and apprehensions, and sometimes when we have to give transfusion, the pyrectic response that starts may precipitate the onset of labor also. So here comes the role of intravenous iron in therapy. When there is no improvement with oral iron and patient is developing oral iron side effects and there is severe iron deficiency requiring rapid intervention. Administration of IV iron is well limited now to the second and third trimesters only. The first molecule, the first kid on the block was intravenous iron sucrose. It was so good that 10 years back we were all using it. Safety was established as compared to the old irons which we did in our pharmacology lessons, which had too many side effects. So when came IV sucrose, it was so good. Minor side effects were there, but the problem was the cap of the dose, 200 milligrams. So we were having to give multiple because 200 IV is simply not going to meet your requirements. Then another molecule, intravenous low molecular weight dextran. It is also time and cost effective. It is we are able to give 1000 milligram IV over 1 hour. There were several studies reporting the safety of low molecular weight iron dextran. But now this we have not used. The newer iron intravenous formulation, which has definitely come and it has replaced everything else, just it has thrown everything aside, is the ferric carboxy molecule, maltose molecule, the FCM, the great FCM, which we are all using right and left, and our women have never been pink more than before. So there is iron isomaltoside also in the pipeline, and there is ferromoxetol also. Well, FCM, due to its widely studied, it has been studied in so many studies. In Indian studies, we have Indian data now. It is a parental iron dextran-free product approved for rapid high-dose iron replenishment. Ferric hydroxy core is there, hydroxide, and a carbohydrate shell. So slow iron delivery. Now, if you look at the side effects of all these iron, so look at FCM. So a higher rate of some hypophosphatemia is mentioned, but then mostly it has no side effects. And iron dextran, there were concerns for anaphylaxis. Then iron sucrose, the number 3, which we all have used. It had diarrhea. Definitely, we all suffered this headache, nausea, dizziness, hypotension. Well, FCM, the biggest thing is that there are multiple clinical trials. So we have data. Hypersensitivity reactions are common with all the formulations. They are mild and transient. Severe reactions are a response to the carbohydrate shell. And almost every individual who has a reaction to one will be able to tolerate the other. So now the guidelines country-wise during pregnancy, they are specified values for oral and IV iron initiation during and pregnancy and during the postpartum period also. We have a quick look at the FCM, the iron, which is so widely used intravenously and easily by us. It is a dextran-free parenteral iron, rapid high dose. We can give up to 1 gram. It is an iron complex, again, we have already mentioned. Immunogenic potential is low. Anaphylactic reactions are less. The design is such that it is, once it goes into the plasma, the blood, controlled delivery in a single 15 minutes. The time is the hallmark, because one side effect, which has been one reaction of anaphylaxis reported in the AIM study, the infusion was slow. It went on for 30 to 40 minutes. So a rapid infusion prevents a reaction. It is, the pharmacodynamics shows that 99 to 99% of the radio labeled iron is taken up. And this is The pharmacokinetics, after a single dose of 100 milligram IV dose of FCM over 1 minute, the serum concentration peaked at a minimum of 15 minutes, and a large volume of distribution is there. So FCM in a dose of 1000 milligram administered during 12 to 24 weeks provides a substantial improvement in iron status. It may be administered in the late second or early third, at least 2 weeks before delivery, because you need to give the drug time to act. Now, it has demonstrated efficacy over a wide range of conditions. With or without functional iron deficiency, meaning that if ferritin is low, she's just 9 to 10 grams and she's feeling weak, still we can give. So better efficacy than oral iron, definitely. No GI side effects and no prolonged drug intake. And it improves the parameters of hemoglobin, ferritin values, and the total iron binding capacity saturation. So parents with the postpartum patients with postpartum anemia also receiving FCM reported a rise more than 2 gram in 7 days and more than 3 gram per deciliter in 14 days. So in addition to postpartum anemia, anemias with inflammatory bowel disease, abnormal uterine bleeding, and congestive heart failure, they also received, had improvement. So there are many 20 database trials. When compared against IV iron formulations, rate of adverse effects is similar. It is reported to exert lower rates of dysgeusia, that is bad taste in the mouth, and hypotension as compared to the other things. So if again adverse effects, the main are decreased blood phosphorus, dizziness, flushing. And now, of all the studies, I feel we all know about the PROMISE study because it was done for progesterone and recurrent miscarriage. And in one arm of the study, they also started giving this FCM. So side by side, this is a side arm of that study, and the number of the sample size is 1800. And what were the results? I will tell you that all these parameters were studied: hemoglobin, ferritin, RBC count, hematocrit, and the mean corpuscular volume, and the MCH and HC. Hemoglobin increased by 3.6 grams and serum ferritin by 16.9. In women with moderate iron deficiency anemia, there was improvement by 2.7 and serum ferritin by 33 microgram. Mild, in also a rise of 1.99 was there. So IV FCM is associated with favorable safety profile in ID of all severities. So if the patient is simply mildly anemic and telling, I'm not going to eat iron, too much side effects, non-compliant, so well, we can offer. The physician's favorable assessment of FCM efficacy and safety in women with iron deficiency affirms its use in daily clinical practice. Again, another study, this sample size was 150. So at 6 weeks, almost 2 times more increase in hemoglobin was noted in the ferric carboxy maltose group compared to the iron sucrose. Iron sucrose, we feel that at least in our part of the country, it is almost gone. It is used only in the government setups. So comparing both of them, for the treatment, iron sucrose versus FCM, mean rise at 12 weeks was higher in the FCM group. It was associated with a greater improvement in fatigue scores. Visits, definitely, obviously, there were less and no serious side effects in either group. So large dose administration per sitting and early rise and no extra pricks, etc. So other studies, I feel that they are all giving us good data. Side effects associated: headache, dizziness, hypertension, flushing, nausea. Hypertension, since we are giving to all pregnant patients, we measure BP before and after. We also check the fetal heart rate with the Doppler, but we have not really got many side effects. Injection site reaction, well, if this drug extravasates, we do get a lot of grief from the patient that you made her skin black over there. Hypophosphatemia. Rare reactions are these which are mentioned, but so far in 3 to 4 years of usage, there is very, very less report of Punjab. There is one isolated stray report in Chandigarh of anaphylaxis with FCM, which was given at a peripheral clinic with no crash trolley over there. So in summary, iron deficiency anemia has so many complications. We know all this. Iron deficiency is a menace for us. In the baby also, preterm birth, low birth weight, start life with a disadvantage, small for gestational age, distress, memory processing disorders, and iron deficiency would be very, very rare in the fetus, but definitely the baby starts life with a disadvantage. FCM offers the advantage of a large dose administration per sitting, and patients are happy. You give them once, and then, definitely for some days, you will not, 7 to 10 days, if they do not want to restart the oral iron, we have to stop it. The reason we can do in the discussion. FCM has been demonstrated in pregnancy to improve the quality of life scores and fatigue levels. Oh, definitely patients come back and tell you they are feeling better, and after the second visit, they are looking pinker. Less discomfort, less pricks, fewer number of visits, rapid elevation. So the FOGSI recommendations are, among the various preparations of parenteral iron, FCM was found to be possibly better than other parenteral iron. Dextran-free IV iron, rapid administration, high dosage up to 1000 milligram, 15 minutes. FCM in postpartum is safe, effective. Postpartum, they will never eat iron. They will just finish up their few days antibiotics and be so busy with the neonate. They will eat only the panjiri and non-iron containing funny foods, which the culture and tradition will dictate, but they will never eat iron tablets. So I think that postpartum, it is a great boon to us. In pregnancy, at least, there is fear, so they will eat iron. Compared to other parenteral iron preparations, FCM has several advantages. Again, we've already mentioned, and FOGSI endorses it as the best option for postpartum anemia. It can be considered an optimal choice considering the GI intolerance with the oral irons. So, more than guidance note under the anemia book, Bharat, these slides are on that. Guidance note on the use of IV iron. More than half of the pregnant women suffer from anemia, and it is further classified as this. And the National Technical Expert Committee on FCM has said that it brings about greater and faster hemoglobin increase, higher stability, or antigenicity is lower, and shorter administration. Again, the same. They have all endorsed all these good points. And they have also given the dosages, again, Ganzoni's formula. So I think I'm exceeding the time. So it is available in 10 ml and 20 ml vials. Even 1000 milligram is approved. So in a nutshell, iron deficiency anemia is the most common cause of anemia. Treatment aspects include lifestyle changes, supplementation. On a nationwide basis, we have to get ads like iron-rich diet, supplementation, dietary modifications, transfusions, and pharmacotherapy. And FCM has demonstrated therapeutic efficacies for conditions associated with functional or absolute iron deficiency. Effective in a pregnancy anemia as well as postpartum. Efficacy is safe and tolerable. Anemia Mukh Bharat is also endorsing it. So that is it about FCM, and I think that we open it for discussion now. Click to exit. Stop share. I think that FCM has changed the way we treat our. Am I audible?
I think it was a very nice coverage, and because somewhere some families, it's a fashion to take tea or coffee after meals, but they don't realize that they are hindering the absorption of iron. The new thing which is entering in our stress is the alcohol, and people are confused with alcohol also, whether it is the absorption of iron or not. There's cereals which is very common in Punjab. We like to have a dal. This is phytate. I think phytate was long before when I was a physiology student. That time we discovered that phytate prevents the absorption of iron. That it's a very new at that time. But just things which is very common. Everybody takes dal. Everybody takes tea or coffee. But it's a overall very nice comparison of both the topics. Both the topics. I become wiser. I must say thank you very much for giving me chance to hear it. Thank you very much.
Dr. Shefali is also here.
It was a wonderful talk, Dr. Ginny, as always, mesmerizing and a power-packed talk. Power-packed talk, as you always are, full with the content and with clear, crisp take-home messages. Two important things which I gained from your talk were, one, to do CBC for patients of infertility who come to us. Because most of us, we start with letrozole, clomiphene, everything, but no CBC is done, HB is not done. So if we start building them up right from there, that will be a step forward in getting pregnant women who are already built up. And second is wider availability and acceptability of iron FCM. I myself in my second pregnancy got iron FCM 1 gram done, and I was better in my postpartum as compared to my first pregnancy. So FCM should be promoted and it should be given to those patients who are not taking iron, whose HB is not improving, and it actually does wonders, as you said. One question which I have is the FCM safe in the first trimester of pregnancy? Oral iron, you said, can be given. Can we give it in first
FCM
trimester?
is not yet approved for use in first to 13 weeks. I would also like the opinion of the House, the FOXY GCPR, good clinical practice guidelines, and the endorsement of even WHO. They are recommending from 13 weeks onwards. And in first trimester, FOXY has endorsed iron amino acid chelate low level. I am sorry to use a trade name, but the FAR20, it contains iron amino acid chelate. It is 30 milligram. So they
And
are
it can
saying
be
you can
given.
use that much. It will not increase the nausea vomiting of the first trimester. Because women who is 9.2 at her first visit, you can give her iron amino acid chelate. If she is compliant, she may become 11, 12 by the end of first trimester.
9.2 is still okay, but sometimes we get 7, 6, 8 also. So if FAR20
Yes,
can,
FOXY
this
has
can be
endorsed
given, then that
this
will be
to
better.
give iron amino acid chelate in the first trimester, 30 milligram.
But FCM we can't give till now in the first trimester.
Madam Vaishali and seniors, what would you like to say?
Ma'am, what you have said is absolutely right, and what a fantastic talk, and so much clarity, because this is a vast topic and you have covered everything about it right till the puerperial phase, and you like truly said the way our culture is and the way the post-delivery lady, the things she eats, the food is does hardly have any iron or protein in it. So very practical points you have given us. So much we have learned in your talk, ma'am. Very, very informative and
we have a
excellent
really big
topic.
problem with the Hindu community. They don't eat healthy. The Sikh families are very intelligent. They will come and give chicken soup to the lady. They will come and give her fish ki ye hamare bacche palegi, ye sherni hai. And this is how they talk. And the Hindus, they will tell isko to wo suji ka roti do aap. Suji to aur bika wo
दाल में घी डाल के खिलाओ बस. घी डाल दो हर जगह.
Ghia dete rehte hain. Ghia is pale. It's like lemon shaped in color. Dr. Manu, Ghia has what iron? No iron. Ghia is Loki. What iron Loki has? If you ask them to take palak, they will say उससे
It has
गैस हो
fiber.
जाता
It has
है. हाँ,
fiber.
गैस हो जाता है. पालक से गैस होता है. पालक से the spinach they will say and rajma is the source of iron. They will say उससे गैस हो
बाय
जाएगा
हो
बच्चे को.
जाएगी, बाय हो
अब बच्चे को
जाएगी.
गैस हो जाएगी.
Dietary education is very important.
Very
and it
bad
should
in
start
North
in
India.
pregnancy only.
Yeah.
And this is even in education.
Some of them are dieting so much that they will be 51 kg at marriage, and 6 weeks postpartum they will be 48 kg. They will see the biggest dietitian, मुझे weight कम करना है, and they will be like 8 grams. खाना ही नहीं खाते. And the other group is the PCOs who are eating maida, who are also 8 to 9, and they are just eating these refined sugars, the donuts and the burgers and the pastas.
True. So very nice talk, and it was good. Dr. Shefali has also joined, and everybody, the entire team is here from Ludhiana Society.
Dr. Manu and I have used a lot of iron sucrose because we used to give multiple injections. Remember, Dr. Manu? They would come after every 1 or maybe 10 days, dubara injection. The FCM is at least,
And we get good
obviated
results
this.
also.
We used to give alternate day injections for this iron sucrose in our PG time. But FCM is actually better. You give once, you can build up hysterectomy patients also, you can build antenatal also.
Correct. For gynec indication also, it's very useful. You give one FCM, it really builds up the HB.
You can reduce the need for blood transfusion.
Madhura, I also took iron isomaltoside myself. I had heavy menstrual bleeding. Now I am menopausal. I took it by MR gave it to me. I said, "Mujhe iron nahi khana." So he gave me iron isomaltoside. It was very smooth. I took it IV. It was a nice experience. Not yet really available, na, isomaltoside. आया नहीं अभी इंडिया में. He gave me one. Again, I am going to have to use a brand. Lupin वाले ने दिया था. So I took
हमारे
it.
टाइम में जेक्टोफर चलते थे. I remember I was anemic in my pregnancy and only Jectofer was available. And they were so painful injections in both my pregnancies. Now, after this iron sucrose, it is like a blessing. It's not painless.
FCM.
Madhura is our antenatal gynecologist, antenatal patient.
And I have actually just taken FCM yesterday. I've really taken it yesterday.
And regarding serum ferritin, even if the patient doesn't have hemolytic anemia, हम लोग ना ferritin करा लेते हैं, क्योंकि किसी का ferritin अगर 100 के ऊपर है तो फिर वो कोई कल को बोल देगा कि आप iron overload करते जा रहे हो हमें.
Correct.
This so we give IV iron when the ferritin is below 30, but it is mostly below 10 also. Mostly below 10.
So actually, that is the correct way of giving IV iron. Need to do serum ferritin. Like
Most
ma'am
of the
rightly said.
gynecs would also have ferritin below 30.
Yes, yes.
Stress.
Mine was 20 when I did last.
Yes. So, madam, Gini ma'am, it was very nice communicating with you and planning this
Thank you,
entire
ma'am. We look forward.
with you, and then and also the Bhopal Society also joined us. And Iqbal sir is here. The entire
Ma'am, sir
webinar.
made so much time. You made so
Yes.
much time. ठीक है.
Such a great personality and pioneer of IVF in India.
Yes, yes.
We have met sir at the webinar. So we are truly indebted to you.
He is
that
father
you
figure
were
for
here.
us. All gynecologists in our district and maybe mostly Punjab. Entire.
Right, right. Yes, yes.
So we wind up.
Thank you so much.
Thank you, Dr. Manu.
Yeah.
Thank you, Dr.
Thank you,
the
ma'am.
Pune team,
Thank you,
sir.
Dr.
Thank you
Gini.
so
Thank you.
much for
We
taking so
propose a
much
vote
time.
of thanks also. Madhura,
Yeah.
go on.
So thank you so much, ma'am. It was a great session. The discussions later on were especially very interesting. And so I'd like to propose a formal vote of thanks. We are blessed to have such big dignitaries with us. Jaideep madam was here. Like everybody said, Dr. Ahuja has been here throughout the webinar, which is a great thing. I think Meenu ma'am has joined.
Yeah.
I think Meenu ma'am was there, no?
No,
Hi everyone.
Yeah.
Hello.
Hello, hello.
Hi.
So Dr. Meenu Agarwal is the one who has started cutting edge webinars with the
Thank you.
Pune OBGYN Society, and
Congratulations,
she's
Meenu
recently.
ma'am, on
Thank
being
you,
the
ma'am.
vice
Meenu ma'am.
president.
Thank you so much. Thank you, Dr. Gupta. Thank you.
Yeah, carrying forward the webinar under her advice and guidance.
So it was her idea to start these webinars, and we've been continuing. So we missed you, ma'am, for last 2-3 sessions.
Yes, I did. I also missed it. Thank you.
So today it was with Ludhiana and Bhopal Society. Everybody from Ludhiana is here. Dr. Gini ma'am, Dr. Manu, Dr. Shefali, Iqbal sir, everybody is here. So I would like to thank everyone for joining today, the Ludhiana OBGYN Society, Bhopal OBGYN Society, the speakers and our esteemed chairpersons. Thank you so much. It was a great experience and it was very enlightening to hear all of you. Vaishali madam, also your talk was great. It was a different topic and like what we face every day, especially in the last few days. Like you said, dengue was so common. So I'm sure everybody benefited from it. I would also like to thank BSV, who has been helping us with the webinars, and POGS, Aarti ma'am, Meenakshi ma'am, Amol sir, for continuing these webinars, and RX Events for the coordination and smooth progress of the program. Thank you so much,
Thank you so
everyone.
much.
Thank you very much.
Thank you, ma'am.
Thank you, everyone. Thank you.
Thank you. Yeah. Meenu, how nice of you to join. Mute pe ho.
Recording stopped.